I got my period when I was 12 years old. What I remember was being in pain.
Vomiting and dizzy and sick, and that was my first period.
High school, I was told nothing about menstruation, and I thought that I was by myself, which was the worst, especially during your teen years when you think that you're by yourself anyway.
I believe that none of them have got theirs yet, and I'm the only one out of the group, so I don't like to talk about it with them if they haven't had theirs yet.
I'd go to sick bay and I'd very much think that I was just putting it on, wanting to go home early.
On my 11th birthday, it was awful. It was scary.
I wish that my diagnosis was sooner.
We went to a gynaecologist to try and sort it out, and they sort of passed it off as just heavy bleeding and period pain.
In the UK, the average diagnosis time is 7 years. I was fairly lucky, I guess. It only took me 4 to 5 years.
I didn't finish school, no. I dropped out because of endo.
So I'm just going to touch on period pain and some of the research that we found, our study data, some barriers, first line measures, early diagnosis and the management pathway. So in 2005, my colleague Dr. Anne Snedden and I had been really concerned about the women in their 30s and 40s that we were seeing who had had such a big impact on their lives. And we really wanted to go back and work out what was happening in the teenage years and whether we could diagnose it earlier. And what we found was that there was very little Australian data on what was a normal period in teenagers. So we decided to do the MDOT study. And we surveyed over 1,051 young girls aged between 16 and 18 years. So these are girls in years 11 and 12. And certainly what we found was that pain was extremely common as part of periods, and that's the whole range from mild to severe. But certainly that crampy pain that women get with periods as a result of the prostaglandins and inflammatory chemicals that get released around that time was common for nearly 75% of the, well, 3/4 of the sample. And also PMS symptoms were really highly reported there at 96%, and mood disturbance is something I think that's really under-evaluated and in young women as a part of periods. And most interestingly, that there were 11 girls who said that they didn't have any pain or any symptoms at all. So what we were concerned about was the 25% that reported marked menstrual disturbance. And these were the girls who said they had severe period pain, so that's scoring 8, 9 and 10 out of 10 for their pain. The girls who were missing school, who reported moderate to high interference on their daily life activities, and certainly the 26% who reported 5 or more period-related symptoms, and it seems like the ones with worse pain reported more and more PMS symptoms. But we also had 10% of girls who reported atypical symptoms associated with their periods, and that's the bowel pain, bladder pain, pain with sexual intercourse. Now, a third of our sample had already been to see their GP about their periods. 22% said they were already on the pill, and 14% said they were put on the pill specifically because they had pain. 9% had been referred to specialists, but only less than 1% had had an operation to investigate, and less than 1% actually had a diagnosis that was menstrual related, and that, as you can see, is mostly polycystic ovarian syndrome. 2 had been diagnosed with endo and 2 were under investigation. So what's normal periods? So pretty much all of the, the painful cramps, the fatigue, headaches, backache, thigh aches, all of those are reported commonly with periods. And I just want to define the word dysmenorrhea that you hear quite frequently. It is the medical term for period pain, but it's really a big scary word for young girls because they come in and go, oh, my doctor said I've got a disease and it's dys something, and they get very frightened. But it really just means period pain. But we do talk about primary and secondary period pain. So primary is if the period pain is related to just the period itself. Secondary period pain is if it's related to an underlying cause such as endometriosis. So how do we then distinguish from what's normal period pain and what's endometriosis? So in this next slide, the symptoms on the left are the ones I've just been talking about, and most women with endo will report a lot of those. But the difference are the list on the right, which is women talk about their pain starting before they're bleeding, that it's severe, sharp and stabbing. It will often involve their bowel, sometimes the bladder. Often sex is painful. They might have premenstrual spotting. They might talk about sharp rectal pain, shoots upwards, and ovulation pain can be severe for some women. So the literature suggests we don't actually have prevalence data for teenagers strictly on endometriosis, but in the adult women they talk about a range from 5 to 15% of women. There's a diagnostic delay of around 6 to 12 years for women, and certainly the teenagers who have ongoing period pain, chronic pelvic pain that doesn't respond to non-steroidals and the pill are often the ones found to have endometriosis. So some other markers that have come out in the literature for endometriosis is that often it's the girls who talk about period pain that starts from the very first period or shortly after. And for the more deeply infiltrating disease, the histories of those girls will often show a family history of endometriosis, having to take time off school during their periods and needing to start the pill early, use it more frequently and for longer. So there's lots of barriers in terms of delaying diagnosis, and there's a whole list there for clinicians in terms of just thinking that teenagers don't have it and the appearance can be different. The last point is interesting research that women presenting with infertility are diagnosed in half the time as women who present with pain. There's also barriers for young women in terms of, once again, what's normal period pain, not knowing about endometriosis. There are still taboos around discussing menstruation. They might be embarrassed, they're scared of having a vaginal examination, so they'll delay their presentation to a health professional. And it's even once they get to the health professional, sometimes it's actually hard to articulate the symptoms, and sometimes they don't connect that the bowel pain might be related, so they may not even mention that. So the first line treatment is really a process of trial and elimination, and it's really about starting with the right sort of pain medication. And the non-steroidal anti-inflammatories shut down those inflammatory chemicals that get released with a period, and even within the lesions of endometriosis. You can add paracetamol to that, and sometimes starting 24 to 48 hours before your period, you can be quite effective at shutting down those chemicals. Exercise, especially before a period, is another way to flush out those chemicals, bring in endorphins, increase circulation in the pelvis. Healthy lifestyle measures, as Susan's mentioned, really important. We know that even in the diet, some women struggle with certain foods that they don't tolerate very well before or during a period. And bowel function is really important as well, as is stress management. So stress and anxiety are like a volume button. So as soon as you get stressed and anxious, you're releasing more chemicals, inflammatory chemicals that increase your pain. And medical management, as previously mentioned, and will be discussed further today. So how do we do a diagnosis? Well, we can make a provisional or a presumptive diagnosis based on the pain and symptoms that women are reporting. And look, there's a group of women who actually, may report some endotypical symptoms. They actually respond quite well to hormonal treatment, such as the pill and other measures, medical measures mentioned, as well as the non-steroidals. And they can probably delay surgery if their pain and symptoms are well managed and it's not taking over their life. Hormonal treatment is considered protective, but we still really do need long-term data on that. So to get a definitive diagnosis is through a laparoscopy, and which most of you may have gone through. And once again, how do you make that decision about when to have an operation? And really it's about your pain and symptoms. If you haven't responded well to treatment, and you've maximised your lifestyle stuff. If you've got an endometrioma greater than 4 to 5 centimetres, then it's likely that you might head towards a laparoscopy for that, and if there's been a fertility delay. But, surgery has risks, and so the expected benefits should outweigh those risks. This is just a picture of very subtle disease that we see often in young women. So they're just the red flame-like lesions on the left uterosacral ligament there, just above the pouch of Douglas. And that's very subtle disease as well on that right pelvic side wall. So what do we do? So the aims for management, as we've sort of covered, are sort of controlling the pain and symptoms, stabilising the disease and the activity of the disease, and preserving fertility should you wish to have some babies. So really it's a combined approach for managing menstrual disturbance and endometriosis in right through, whether you're a teenager or whether you're 45. So it's important to get all that lifestyle stuff happening, and that's going to be your major way of controlling this disease and the impact it has on your life. What I say to women is usually it's that combination of lifestyle and medical management that will help most women manage endo and menstrual disturbance. When that's not working, then it might be time to have surgery. But even if you have surgery, you still need to come back to that long-term lifestyle measures and medical management. Now you need support to do this, and obviously the first thing is all the things you can do for yourself, so that's really important to be active in that. But there are lots of health professionals, and as Susan has mentioned, the pelvic physio would be a really important one to get a really good assessment, to see what's going on. Nutrition, if you've got issues with your diet and your bowel, and we'll hear more about that next from Cherry Coe. Psychology is important. Pain psychologists, so other methods of pain, sort of non-pharmacological methods of pain relief, and sex therapy might be important, as well as complementary therapies. And of course the support you get from your family, friends and support networks. And now we have, the Endo Active Facebook site, we've got our the Canberra Endometriosis Network, there's also Endometriosis Australia, good moderated sites where women can share their journey with endo. And they need to be balanced, so not all negative, there needs to be positive encouragement and support in there as well. So this is just to show you that while endometriosis might cause pain with sex, or bowel pain, or bladder, or musculoskeletal, there are a lot of other things going on in the pelvis that can also contribute to pain, and Susan has described that very well for us. So it's important that you identify all of your health issues. There's a lot going on in the pelvis, and you add in there the bladder and the bowel and the uterus, it's a very busy place. Just the impact of disease is significant, and we did some research with 10 focus groups, 35 women across 3 age groups, and these were women who'd been diagnosed with endo for more than 12 months. And certainly the top 4 points in each group are the same, just in different order for each age group. But you can see for the young women that education was a significant factor, and we heard in the video clip before my presentation about the girl who said that she just couldn't finish school, and certainly we see young girls who do have trouble completing their studies. So from our MDOT study, we identified some of the markers for menstrual disturbance. We've got a 10-question screening tool that we've been trialling through our centre, and which we hope to now take back into the schools and repeat the MDOT study so we can validate it against that original tool, and it'll be good to have some new data 10 years later. So what we want is a lovely pathway so that girls can screen themselves and self-manage, then go to primary health care when they need to, and then hopefully primary health care can refer on to secondary, what we call secondary tertiary specialised care if needed. Just the last study I want to mention is one that we did looking at communicating endometriosis with young women. It was just a small online survey. We had 131 women aged 16 to 25, and about 50% said that they'd heard of endometriosis, but they certainly wanted to know what the signs and symptoms were, what it is and the risk factors. Their preferred sources for finding out was at school and websites, and certainly the school came up in our focus groups as well, that that's where we should be starting with this education. But girls were still comfortable to talk to a doctor or a parent or a friend. And interestingly, the older teenage girls thought that boys should learn about endometriosis as well. Yes. Hear, hear. So in summary, period pain, mood disturbance and PMS are very common, but early menstrual disturbance is indicated by severe pain, school absence, the lifestyle interference and multiple PMS symptoms. The endomarkers in the literature also talk about school absence, needing to go on the pill early, having a family history, and the pain starting early after the first period. And also if there's a poor response to first-line measures. We know there's a high impact from this disease, and even menstrual disturbance has a high impact. Early identification is important. Remember, it's a stepped approach. There's not an instant fix, and there's no magic wand. I've been looking for the magic wand. I can't find it. So if anyone does, let me know, but there's no magic to this. It's hard, dedicated work. Obviously the first line measures and the combined approach is really important. So it's not just one thing that's going to fix endo, it's doing that combined approach and that multidisciplinary group of people that you get to work with to support your care is really important. You need to actively self-manage, don't wait to be fixed because it will never happen. And remember, you're a whole person, not just a pelvis. As we've heard, but you need to address all of your health issues to get your overall health ideal. Thank you very much.